Hello, and welcome to the Guthy-Jackson Charitable Foundation Education Center and the NMOSD Grand Rounds series. We welcome everyone in attendance and remind those attending that the Guthy-Jackson Charitable Foundation is proud to be a source of information about NMO and related conditions. The content of the following presentation is based entirely on published data and expert opinion. GJCF is not a clinical provider. It does not offer or represent diagnostic, therapeutic, or clinical care recommendation or advice on personal health. All patients and caregivers are advised to consult with their healthcare team for specific information. The NMOSD Grand Rounds series has several overarching goals that we'd like to summarize here. First, each presentation in the series is a practical summary of latest information on the topic. Each presentation is designed to emphasize key themes and, where available, clinical pearls. The series is intentionally designed to be inclusive of non-specialist audiences. And within each presentation is a pocket guide near the conclusion of the presentation to highlight key points and reference ideas. Every presentation in the series is eligible for continuing medical education credit. To access this credit, please visit the Guthy-Jackson Charitable Foundation Education Center using the QR code shown here. Select the session you're interested in and register for viewing that session. Once you view the session and fulfill the CME criteria, please then access the credit by receiving CME certification online. My name is Michael Yeaman, and I'm an advisor to the Guthy-Jackson Charitable Foundation. Today, we are delighted to welcome Dr. Jacqueline Palace. Dr. Palace is a professor of clinical neurology at Oxford University and consultant neurologist at the Oxford University Hospital Trust. And her presentation will focus on evidence-based rescue strategies for relapse. Jackie, thank you so much for being here today.
Good morning, good afternoon, good evening, wherever you are. I'm delighted to be able to talk today about the evidence behind treating acute attacks in NMOSD and MOGAD. Here are my disclosures. I would like to caution you that, in fact, there are no licensed treatments for acute attacks in either of these conditions. Disability in these antibody diseases are solely relapse related, and I'm going to examine the relapse associated disability that occurs. I'm going to also discuss the evidence in how delaying treating these attacks increases residual disability. Also, if you don't treat them aggressively, this will also increase the disability. And of interest, not only does this treatment affect the outcome of their disability, but it may actually reduce their risk of future relapse. I'm going to see if there's any data that directly compares IVIG with plasma exchange, and then also discuss other potential treatment options of acute attacks. So we'll start with looking at relapse-related disability. This is from a French study looking at the recovery from the very first attack. And green is complete recovery, and red is no recovery, and then yellow is obviously partial recovery. And you can see that double seronegative NMOSD patients do worse. They have more red and least green. Aquaporin 4 positive patients do slightly better. They have less red, a little bit more green, but it's very clear that MOGAD patients do best. However, I'd like to point out that only 30% of MOGAD patients from their very first attack actually completely recover. And therefore, this data suggests that we need to do better. We need to treat these attacks much better. We're not doing a very good job so far. This is looking at residual disability in aquaporin 4 NMOSD attacks. On the x-axis, you can see the attack number, and on the y-axis, you can see the residual disability according to the EDSS score. And the first thing you will notice is that the very first attack has a big age effect, with older patients being left with much worse disability than young patients. However, the step change with subsequent attacks is much steeper with younger patients than older patients. And this, of course, really shows us how important it is to prevent relapses as well as to treat the acute attacks well. Now, if you look at the mean residual EDSS per relapse, and you exclude the onset attacks, which are often most severe, you get a score of 0.3. But the EDSS from multi-site attacks is much greater. It's up to about 1. Reassuringly, residual disability has reduced over the decades. And before 2000, your mean EDSS score per relapse was nearly 0.6. And since 2000, it's half this. And I'm sure this relates to the fact that physicians are increasingly aware to treat these acute attacks urgently and aggressively. If we look as if there's any predictors for poor outcome, and we look in MOGAD, you look at the onset phenotype and the recovery. Now, white is full recovery and red is poor recovery. There's more red if they present with an LETM or a bilateral optic neuritis, so they do worse. And in fact, there's very little full recovery in transverse myelitis attacks, whether they are long lesions or short lesions. There's also an age effect, as we saw in aquaporin 4 disease, and younger patients have more white, they get more full recovery. And then patients from 20 to 45, a bit less, and then older patients even less. So the older you are, the less likely you are to recover. I want to highlight something very important in MOGAD transverse myelitis. These patients can present with catastrophic transverse myelitises, they can be paraplegic, but they usually make a very dramatic improvement with treatment. And you can see at the top here how overall the patients, very few of them will have an EDSS of 4 or greater. But many are left with sphincter and sexual dysfunction that's really a hidden disability. And in this cohort, permanent bladder dysfunction was seen in nearly 1/3 of the cohort. 17% had to use long-term catheterization, and 3/4 of males with a transverse myelitis at onset had problems. 1/5 of patients have significant bowel dysfunction, and 1/5 of males also have erectile dysfunction, but nearly half of those who present with a transverse myelitis at onset. And the reason I'm highlighting this is if you see a patient that you've treated with IV methylprednisolone and they make a dramatic motor improvement, you shouldn't then just be sending them home, hoping that their sphincter function will come back. You should be treating this as seriously as you would the motor recovery with more treatment, second-line treatment. So I want to now talk about delay in treating and the effects this has. This is a retrospective analysis from the German cohort, the NMOSD cohort, where they analysed 871 attacks in 185 patients. They looked at those that were treated within 3 months of onset, and the majority of them, you can see 84%, were aquaporin 4 antibody positive. And every day of delay significantly affected their chance of recovery on the univariate analysis. It was a trend with multivariate analysis. And I've extrapolated this data to show you that a 7-day delay means a 30% reduction in the chance of complete remission. And by the time you've delayed by a month, it's 77% reduction in complete remission. So every day counts. If we look at the optic neuritis data, here I've shown you a French study, and they've looked in MOGAD patients with optic neuritis, and they've taken a cutoff of 10 days. And what you can see is those that are treated within 10 days have a better visual outcome than those who have delayed treatment, but also they have less retinal nerve layer fiber thinning on OCT than those do if you delay the treatment. This is an Israeli study, a mixed group of aquaporin 4, NMOSD patients and MOGAD patients. They, in fact, have used their y-axis in the opposite direction, which is a bit confusing. They've used a 7-day cutoff. Patients that are treated within 7 days had better visual outcomes than those that were delayed. Also, there was an age effect, which isn't surprising from what I've told you earlier. And the actual disease status was not a factor. They then did ROC analysis and tried to find the optimal treatment time, and they showed that 4-day cutoff was important. If you delayed beyond 4 days, then your chances of failing to regain full 20/20 vision had an odds ratio of over 8. So a big effect within 4 days of delay. So that's showing some examples of delay in treatment. But what about the treatment that you use? Does it matter what treatment you use? And does it matter if you have to use second-line treatment? Is that useful? So first of all, we start with apheresis and plasma exchange. This is the retrospective study on the left that I've already mentioned from the NMOS cohort, and on the right, another follow-up study where they've looked at the effects of apheresis in 105 patients who were treated with 207 attacks with this treatment. And again, the majority are aquaporin 4 antibody positive. The first thing they showed when they looked at the different treatment types was that you were better to treat transverse myelitis patients first line with plasma exchange or immunoabsorption. So here we have the high-dose corticosteroid group. These are the plasma exchange group. And I have to say those that needed plasma exchange actually were more disabled. So really had a higher bar to treat, but they managed to show that 30% of these with plasma exchange, despite the higher disability, reached complete remission, whereas only just over 10% of those given high-dose corticosteroids. When they did their multivariate analysis, they were able to show in the groups overall that plasma exchange first line versus high-dose steroids gave an odds ratio of over 4 of achieving complete remission. They looked at the effects of first line versus second line and subsequent lines on the outcome. And they didn't show a difference in complete remission, but they showed they could reduce the number of patients who had no recovery from 16.4% down to 8% after a second treatment. And it did go down by 1% with subsequent treatments, and that was significant, but it is a very small effect with third line and subsequent line treatments. In their analysis, looking at the apheresis group, they showed that first line versus second line apheresis had an odds ratio of over 12 of reaching complete remission. And actually, I think it's very important to note that aquaporin 4 positive patients versus negative had a very large odds ratio of over 30 at reaching complete remission. So it doesn't really look like the antibody negative patients are doing very well, even with apheresis. This is another study from Martinique, looking in NMOSD and time to plasma exchange. So they took 60 patients. They'd had the plasma exchange for severe attacks. The majority had had IV methylprednisolone. Only 2/3 of these were aquaporin 4 positive. And they showed that the delay in giving plasma exchange reduced those patients reaching complete recovery, which is in the pale grey over here, over time, and also reduced the percentage of patients that had a good recovery, shown in green. Now, if you look at complete recovery, beyond 5 days, you're starting to reduce the chances of this. And if we look at improvement, good recovery, you're reducing the chance of a good recovery beyond about 10 days. What about in MOGAD? So this was an international study collected of 205 MOGAD patients with 211 attacks that had been treated with plasma exchange. And on the x-axis, you have days going up to about 6 weeks. And you can see this is the time from onset of the attack to plasma exchange. You can see that as you delay your treatment, you reduce your chance of complete recovery and also clinically significant improvement. So it's important in MOGAD as well. And this is a very nice demonstration from the NMOSD German consortium, looking at MOGAD and comparing apheresis versus IV methylprednisolone. They start with 106 patients. Just going to explain the color coding here. In pink are those who have IV methylprednisolone, and in blue those who have apheresis. And when we look at the outcomes, red is no recovery, green is full recovery, and orange is partial recovery. So let's look at the data. A small number of patients had first-line apheresis, and you can see the outcome here that majority of patients had green. They had full recovery. Only one patient had no recovery at all. Now let's look at those that had first-line IV methylprednisolone, and you can see here in this column, there was about a 50-50 split between those who had no recovery and partial recovery. Nobody had full recovery. Then, if you gave them second-line IV methylprednisolone again, this really didn't alter the outcome very much, maybe a slightly lower proportion of no recoveries and a slightly higher proportion of partial, but no greens here, no complete recovery. But if second-line, they gave apheresis, then you can see here you bring back some patients into full remission and you reduce the number with none. And also down here, if you use apheresis third line, you still bring back some green, some full recoveries. So overall, this is saying that there's a better outcome if you use apheresis first line in MOGAD, and versus later, gives you an odds ratio of complete recovery of 2.6. It seems there's little benefit in this study of repeating IV methylprednisolone, and it's better if you use apheresis second or even third line. Now, maybe it doesn't matter what the underlying disease is in optic neuritis in using plasma exchange, and this is a study reported by the Mayo Clinic group. They had 400 patients with optic neuritis that was treated with plasma exchange. And just to highlight again, these are going to be patients with bad disease. And roughly equal numbers of those with NMOSD, MOGAD, MS, and idiopathic optic neuritis. They very clearly showed that for every week you delayed plasma exchange, you reduced the chances of complete recovery, which is shown here in green. They took the subgroup of patients that had 20/200 vision, or that 6/60 vision or worse, and they compared their outcomes to those in the optic neuritis treatment trial, which is shown in blue, because these patients were only able to have IV methylprednisolone. If you look at the outcomes within a week, there's really very little difference in those that had IV methylprednisolone or plasma exchange. However, if you look at those who had no response to IV methylprednisolone at 4 days, then yes, about 60% of the optic neuritis treatment trial patients would then have a final outcome of 20/40 or better, that's 6/12 or better. But you had a much higher proportion that would reach this target if they'd had the plasma exchange shown in red. If you looked at those who had no response to IV methylprednisolone at 2 weeks, then again, some of your optic neuritis treatment trial patients who had no further treatment did recover to this reasonable outcome, about 40%, but you rescued a lot more if you gave them plasma exchange. And importantly, even at 1 month, none of your patients who had responded to IV methylprednisolone by 1 month improved further, but actually you brought back 50% to a reasonable outcome with plasma exchange. So the point of this is saying, actually, although you should treat them quickly to get full recovery, actually you really should consider, even if you only see them later on, treating them even with a month delay. And anecdotally, I have a couple of patients who we've treated 2 months down the line or even longer with poor visual outcome, who we've managed to rescue some vision. What is the evidence for IVIG? There is less evidence out there. This is a Chinese study, and they've compared patients who had IV methylprednisolone alone or with the addition of IVIG, and that's shown here. I just want to point out a big difference between the groups, which could bias the data, but those with IV methylprednisolone alone, a large number of them were not sure of their aquaporin 4 status, and if there was a difference in their response, then this might matter. If you look at the EDSS score during the acute attack, it's much higher in those that had IVIG added because it's retrospective analysis and they were obviously given it for more severe attacks. And at discharge, both groups reduced their EDSS score, and it was significant in both groups. And the delta EDSS difference was higher in those that had IVIG added compared to those who didn't, and this was significant. Now, if you look at the delta EDSS in different subgroups, you can see that actually the onset attacks did not seem to be significantly different. If we see the p-value here, if they'd had additional IVIG, but subsequent relapses were significantly improved if they had additional IVIG. Aquaporin 4 antibody seropositive patients also had an advantage when they were given IVIG. Now, why is this? I don't know for sure, obviously, but I imagine that obviously at onset, you do not know their diagnosis, and there may have been a delay in IVIG because of this. Here's another Chinese study, and they've compared IV methylprednisolone with IVIG, and then the addition of both together. Now, they've used a different color coding system here. So good is sort of red, orange, and poor is green, and purple is in between. So the overall group data is shown on the left here. And you've got high dose steroids here, and you can see it's about 1/3 of each outcome. And if you look at IVIG, then you have no good outcomes at all and more poor outcomes shown in green. So that might suggest that IVIG is less good than high-dose steroids. And when they looked at both groups together, both treatments together here, it doesn't actually look very different to those that were given high-dose steroids. So the addition of IVIG is not really very impressive. If you look at the aquaporin 4 positive patients, it looks very similar. So it would suggest that there's maybe no difference in the outcome between aquaporin 4 positive and aquaporin 4 negative. And that's actually in contrast with what we saw in the plasma exchange data. So maybe the antibody negative patients might be responding a bit better to treatments with IVIG than with plasma exchange, but they did not present the data for the antibody negative group. Sorry. They showed that severe attacks, however, did show a better outcome if they had IVIG added to the high-dose steroids than with high-dose steroids alone. They interestedly looked at the order of giving the dual therapy, whether high-dose steroids followed by IVIG was the same as IVIG followed by high-dose steroids. And there were reasonable numbers, and what you can see is those that were given IVIG first and then high-dose steroids seem to have more good remissions and less poor remissions. And I can't explain why this is, but maybe even order is important. IVIG in MOGAD, there's very little data out there. This is a 5-country study, and they managed to get only 39 patients with 39 attacks treated with IVIG, and they followed them up for at least 3 months. And you can see this is the EDSS on the left and the visual acuity on the right. Both improve at the end of treatment, but then actually at first follow-up. It doesn't compare it to any other treatments, however, but they did show that there was no advantage in giving high dose over low dose. So I hope I've shown you that delay in treating attacks is a problem and not treating them aggressively is a problem. Interestingly, it may be that treating these acute attacks does something to reset the immune system, but it does seem in a number of studies to reduce their subsequent relapse risk, and perhaps this wasn't expected. So we go back to the Chinese study I've already discussed, where they looked at the addition of IVIG to IV methylprednisolone, and that's shown in blue, and IV methylprednisolone alone. And this is time to relapse. Now, there's no difference with the onset attack as we saw with the outcomes, but with relapse and also in aquaporin 4 positive patients alone, you can see there's a delay if you give them IVIG. And this delay is roughly 10 months. And that would be longer than I'd expect the IVIG to be working. We expect IVIG to work between 4 weeks and at a maximum maybe 12 weeks, but not 10 months. So maybe this is having a disease modifying effect. This is a Korean group in MOGAD. They looked at the effect of treatment, early treatment versus intermediate versus late, but they also looked at other factors in multivariate analysis that might affect their chances of relapsing. And going towards this side, they're more likely to relapse. Now, early treatment within 5 days compared to 5 to 14 days compared to 15 to 30 days, you can see a delay of more than 5 days does seem to increase their chance of relapse. And this is adjusted for corticosteroid courses and other immune suppressive treatment. And you can see nicely on the Kaplan-Meier curve, time to relapse, and they've got a lower relapse risk if they're treated within 5 days or compared to intermediate, and then those that are treated at a delay of 15 days or more, or as pretty equal to no treatment. This is also backed up by an Italian pediatric study. And again, they did a multivariate analysis using a number of different factors, and again, accounting for a corticosteroid course and other immunosuppressive therapy. And they showed that immune therapy within 7 days from disease onset had an odds ratio of 0.15. So that's a big effect at reducing relapsing disease. However, the Australian study could not show any effect of delaying treatment for 7 days on the time to relapse. Is there any good data comparing directly plasma exchange to IVIG? Well, there's very little data out there. This is an Indian study directly comparing patients who have plasma exchange added to IV methylprednisolone or IVIG added to methylprednisolone. It was a prospective open label study. Now note, only 1/3 of them were aquaporin 4 positive. You can see at baseline, they're pretty well matched for EGSS scores, which isn't really surprising. At 3 months, their median EGSS score was improved, but not greatly. And the mean change over the 3 months, the median change was very similar with both treatments. Not very good data. We would hope to bring patients back a bit better than this. If you look at the activities of daily living, there was no difference between the two groups. And then if you take the optic neuritis patients and look at visual improvement, about 50% improved their vision. So not very good data with either treatments, and there was no significant difference. They did show that the EGSS did show greater improvement with plasma exchange in the aquaporin 4 positive group versus the negative group. So again, we're getting this feel that plasma exchange is not such a good treatment for antibody negative patients, but that's aquaporin 4 negative patients, so not testing for MOGAD. Activities of daily living also improved in the aquaporin 4 positive patients with the PLEX, but not with the IVIG. And there was a greater effect on the aquaporin 4 IgG titers with plasma exchange, but I don't think that's surprising because the mechanism of action. And what about other treatment options? Now, we have 2 drugs that some of us use to prevent relapses in these diseases, and that's tocilizumab and satralizumab, which target the IL-6 receptor. And this treatment came into being because people had noticed that the IL-6 levels, and this is in the CSF during acute attacks, was high in MOGAD and aquaporin 4 patients, but not in MS and other neurological disease controls. But of note, actually, the levels are higher during the acute attack than out of attack. This is in MOGAD. It's also been shown in NMOSD. This is one example. There are many others. This is even in the serum. It's much higher during relapse than during remission. And you can see the individual patients' levels shooting down during remission. So if this drug is going to be useful to prevent relapses, it makes sense to suggest that it's going to be even more effective in reducing the effects during acute relapse when actually IL-6 levels are particularly high. There's no real published data on this, but there are anecdotal reports of people using this, particularly in catastrophic MOGAD ADEM with good effect. What about complement therapies? Can they have a role? So to remind you that aquaporin 4 is clustered in orthogonal arrays and has monovalent binding of IgG. Both of these together seem to be the explanation for why they bind so efficiently complement and activate it. Whereas MOG is expressed as a monomer, and we have known from recent data, and I would like to thank Dr. Madder for lending me these slides, that the addition of the intracellular portion of the MOG monomer holds these MOG monomers together quite closely to allow bivalent binding of the antibodies. And it may be that because they aren't clustered together, MOG, it's a monomer, and because it binds bivalently, you can see how this might alter how efficiently it can actually bind complements. And this is one of the explanations for why it may not activate complement as well. This is backed up by pathological data where complement binding is pronounced in aquaporin 4 NMOSD, but is much weaker in MOGAD. And so there's a theoretical reason for using complement inhibition during the acute attack when actually it's particularly apparent. And again, there is no published data on this, but I know of anecdotal cases where people are using it in NMOSD catastrophic relapses with good effect. So if we go through what this all means, there is convincing evidence. I think you'll say that PLEX works in aquaporin 4 NMOSD and MOGAD, and the earlier, the better. But of course, there are completely practical issues in giving it to all patients first line and very early. Maybe we should be thinking about selecting those who we know have poorer outcomes. So for aquaporin 4 disease, first attack outcomes tend to be worse, older patients do worse, those with transverse myelitis, and also previous poor recovery will predict a poor recovery. For MOGAD, they tend to be worse outcomes with the first attack, again, older age, transverse myelitis, as I've shown you, and also severe disability at nadir. But I have to say that late PLEX is also still worthwhile, and I think even beyond 1 month. There is much less data on IVIG, and the evidence for IVIG being better than IV methylprednisolone is really less clear. We haven't got good evidence for that. We do for PLEX. We don't have direct comparison between plasma exchange and IVIG and which is superior. My own view is that I feel that PLEX is likely to be better overall, and most people use it, which is probably why there is less evidence for IVIG. Aquaporin 4 antibody negative NMOSD, and I've said here not double seronegative because most of the studies did not actually remove MOGAD patients because they weren't able to test for MOG antibodies, do seem to respond less well to apheresis. And there's good theoretical reasons and anecdotal reports that the biologicals that target IL-6 receptor and complement C5 may be useful in acute attack treatment. And I think watch out for this. We will be getting data published in the future. So here's my pocket guide. Urgent IV methylprednisolone treatment the minute the patient arrives, and I often aim for a minimum of 5 days of 1 gram going up to 7 days. And you've got your patients with severe attacks or high risk of doing badly, or those with residual disability, prompt or early plasma exchange or IVIG if you can't give them plasma exchange. And then I recommend that you follow these patients on with a tailoring dose of prednisolone while you're awaiting the antibody result if it's their first attack. Some of the things that you should remember is that you should be aiming to return your patient to the pre-relapse level. It's not always possible, but this should be your aim. That second-line PLEX is still effective even late, and that second line, selecting PLEX is better over IV methylprednisolone again. And third line is probably a little advantage for giving that a very small pullback of a few patients. And theoretically, as I've said, acute biologicals targeting IL-6 receptor or C5 may help in severe cases, and we look forward to seeing this published. What are my clinical pearls? Well, treat urgently, and as I said, aim for complete recovery, and this is to minimize residual disability. Remember, treat sphincter disability as you would motor disabilities, is a particular problem in MOGAD. I also like to mention that some patients, when they have an optic neuritis, have reasonable visual acuity, but have visual field defects, which actually can block them from driving. And so you should also treat visual field defects as seriously as acuity. There is good evidence to treat with plasma exchange and maybe IVIG early in severe attacks or in those that exhibit incomplete recovery. Consider acute biological therapies that I've mentioned if there's a poor response. But also remember that you may, in addition to improving their recovery, reduce their risk of subsequent relapse if you treat these patients well. Thank you.
Jackie, thank you so much for this excellent presentation. Very clear, very logical. Well done. Thank you so much. There are a few questions that we'd ask you to address. Maybe we could go to the first one. So the question is, are there specific indications where you would automatically go for high-dose steroids, IVIG, or Plex over one of the other modalities?
So I've already mentioned maybe the instances where you'd go straight for Plex based upon trying to get a good outcome, severe disease, patients with poor prognosis. If you can get it, you would go straight to Plex. But often actually you'd add into high-dose steroids as well. But there may be other contraindications that might make you target different treatments. If you have a patient who has gross obesity, brittle diabetes, has had psychosis with high-dose steroids, or severe osteoporosis, we've had a couple of patients with aseptic necrosis, then you're not going to want to give them high-dose steroids, so you're going to be choosing an alternative. If you've got a patient that is very sick and hypotensive, they might not be suitable for plasma exchange. IVIG may be a good treatment if you've got a patient with a severe infection or sepsis. So I think there'll be other medical problems. It will also depend on whether they've had side effects from a treatment previously, a sterile meningitis with IVIG. Maybe you won't want to give that again. So yeah, there's a lot of other reasons why you might select one of these specific treatments other than just for the good outcome.
Yeah, thank you so much for those insights, Jackie. Another question is, how would you manage patients with mild symptoms and no other abnormalities on exam? Uh, for example, whether a pseudo relapse or a mild relapse might be involved.
This is a real practical issue. People become very anxious with their disease. That's understandable. We tell them the minute you get a symptom, you get to A&E, and it could be anything. They might have come with an optic neuritis, but you tell them, well, it could affect your brain or your spinal cord. So you've got to look out for everything. And so patients can sometimes become so anxious that they rock up to A&Es or ring us up with pain in the eye, bit of tingling in the legs, and say, this is how it started last time and I'm worried. And it can be a real problem because we're saying treat urgently, treat soon, but also you don't want to overtreat. Obviously, there's a problem with overtreating because you're given too much high-dose steroids, which is not good. But if you have actually diagnosed a patient with a relapse, it's also going to have a knock-on effect on your decision-making for their relapse prevention, because you're going to move on from a different treatment. What I tend to do is if they have a mild relapse, they have a bit of pain in the eye, and there's no change on examination or on investigations, then we probably treat the first attack, just assume it is a proper attack. We'll then say if it's an optic neuritis, look at their OCT downstream, because unfortunately, if they don't have disc swelling, the OCT, all you'll see is progressive atrophy in the majority of patients, but over 6 months to a year. So you're not going to have, it's not going to be useful in the acute situation, but I might then see what it does downstream. If it doesn't obviously atrophy, I might be thinking, well, maybe that wasn't a real relapse. If it does atrophy, I'm pretty sure it was a real relapse, and that will affect how I treat them subsequently. If there's no evidence that it's a relapse subsequently, as well as at the time, then what I will say is the next time it occurs in the same way, we might say, look, let's hold off treating, but watch you very carefully. And the minute you show any signs, then we jump in with treatment. So that's really, it's not always easy, but that's how I would manage it.
Thanks, Jackie. That's really helpful. Another question, are there ways to aid patient access to optimal acute management when a patient presents, let's say, to a different location or a different site as they're traveling or across the country, for example?
Yeah, so most patients actually don't live close to where an NMO expert is. And that means that the majority of the time they're going into hospitals and A&Es, and people have half the time haven't even heard of these conditions. They're not aware of the urgency of treating. And if they do treat, they don't investigate. So what we've done to aid this is produce an emergency card that patients take into A&E, and we've revised it a few times. It explains very briefly that these patients can have catastrophic attacks and that they can be left with residual disability if they're not treated urgently, that they actually need to be investigated or examined by an expert, a neurologist and an ophthalmologist, depending on what their symptoms are, and that they actually need investigations as well. And the reasons why they need the investigations to confirm that it's a relapse because it affects outcome. It's a very simple form. It's not very complicated, but just to get the basic principles over. And therefore, wherever they rock up, they can show this to whoever's seeing them for the first time to call in the relevant experts. We also have the details of their neurologist and also their NMO specialist on this form. And we do encourage the physicians to contact us if they're not sure what to do.
Thanks, Jackie. And I think there are similar kinds of materials available in the US and elsewhere, but these are really helpful, practical solutions. Jackie, a question about antibody and titers. Does measuring antibody titer help to adjudicate a relapse event versus a pseudo-relapse in your experience?
Yes, so this is not a straightforward answer. We have recently analysed our data and other people have looked at this. For the MOG antibody and the aquaporin 4 antibody, the titers increase twofold or more in about 40% of patients if they're relapsing. That means that the majority it doesn't. So if it doesn't go up, it doesn't rule it out. If you look at patients in remission, you see that double increase only in 10%. So it is much less frequent. But clearly, it's very obvious that the actual titers themselves are not going to tell you a definite yes or a definite no, but they might add, if you take into consideration your clinical opinion, your imaging, your OCT results, and the titer all together might build a bigger picture, but I wouldn't use it on its own. The only thing I would say is if they become MOG antibody negative, they have a very, very low chance of having a relapse. And under those conditions, I then start to think about whether it might be a pseudo-relapse. So the only really hard and fast useful result would be a negative MOG antibody. And it's never say never, because you know there is the odd case where that just doesn't obey that rule.
And Jackie, just to follow on to that question, do you use GFAP or NFL levels as indicators of relapse in your assessment?
So I think I would use these if I could, but we don't have access to that in those levels in the UK. I think you need to also make sure that they are all adjusted for age, and that the timing of the assessment can vary the results a lot. So I do think there needs to be validation of their use, because you may find it's sort of helpful in the same way as antibody titers are, but it's not the be all and end all. Personally, I think that's going to be likely.
Thank you very much, Jackie. And the last question regarding imaging, are you, in your experience, does contrast enhancement assist in imaging interpretation?
So I think there are two things we have to ask about contrast enhancement. Is the contrast enhancement new? The reason being that, and especially with MOGA, but also with NMOSD from the studies, there can be contrast enhancement that lasts for many months. And so if somebody's had, say, an optic neuritis 4 months ago, and you see contrast enhancement, and then they come again with pain and maybe some visual symptoms in the same eye, and you show contrast enhancement, but you haven't done a baseline MRI, you may not see any difference and you don't know if it's new. And I'm always saying baseline, re-baseline, re-baseline, because the number of times I would have found it helpful in interpreting the results during the acute attack if I'd had a re-baseline scan. This is for contrast enhancement, but actually even for the non-contrast enhancing MRI, it's also very useful. And then, does contrast enhancement tell you whether your treatment's working? And if they've still got contrast enhancement, do you then go on and give them a new treatment? Because, as I've just said, contrast enhancement can be quite prolonged and the patients can improve, I wouldn't use contrast enhancement alone to say, well, they need further treatment. If the patient hasn't improved clinically, I'd be treating them. And if they've fully recovered, I would just assume the contrast enhancement is just a delay. So I wouldn't use it for judging whether my treatment is effective.
Jackie, so helpful. Final question. How long do you in your practice continue prednisolone after the acute event and after acute treatment?
So this is important when we don't know what their diagnosis is. When you first see a patient, they could have aquaporin 4 antibodies, they could have MOGAD antibodies, they could be seronegative. And you've given them their acute treatment, you've pulled them back, but you really can't take the risk of not giving them anything until you know the outcome. So I would bring patients down on their prednisolone dose from high dose, maybe 60 milligrams, coming down to 15 or 20 milligrams, trying to get the antibody results back. Now, if they're antibody negative, I would tail them off after a couple of months. There's, at that stage, because many of them will be monophasic. And probably those that do horrendously badly, those that have no recovery, they tend to, in my experience, be the monophasic ones. Now, if they've got MOG antibodies, because of data out there, I would treat them for roughly 3 months, maybe 3 to 6 months, and tail them off, because there's some evidence that may reduce what I would call a rebound relapse rather than a true ongoing chronic relapse. So I treat those for 3 months. And of course, if they're aquaporin 4 positive, then you're going to be looking at long-term immune suppressive treatments to prevent relapses.
Jackie, thank you so much for your insights. Always so helpful. And I'm sure anyone who's attending these presentations will greatly benefit from your valuable experience. Jackie, thank you so much.
Thank you for listening.
We'd like to remind all the attendees that the presentation you just heard is eligible for continuing medical education activity. To receive credit, please visit the GJCF Education Center using the QR code shown here. Select the session and register. View the session to fulfill CME credit and receive certification online. We'd like to thank Jackie and thank all of those who have provided NMOSD Grand Rounds so far. Coming up is Managing Day-to-Day Non-Relapse Symptoms with Dr. Hisham Aboud. We'd also like to invite everyone to visit the Guthy-Jackson Charitable Foundation Education Center, where you can find not only NMOSD Grand Rounds series, but other educational events, presentations, and media for your consideration. And finally, we are greatly appreciative to Alexion and the AstraZeneca Rare Disease Group for sponsoring the Guthy-Jackson Charitable Foundation NMOSD Grand Rounds, and thank everyone for attending. And once again, thank Dr. Jackie Palace for all your efforts and excellent presentation today. Thank you so much.